Hello, and welcome to our webinar for interpreters today entitled Early Childhood Screening and Intervention for Developmental Delays and Autism. I'm Dr. Jennifer Hall-Lande from the University of Minnesota, here with my colleagues from Minnesota Department of Health, and we're happy that you could be here today with us to learn a little more about practices of early intervention, early childhood screening, and monitoring developmental milestones. Our objectives of this webinar today are to familiarize interpreters on basic concepts and terms in early childhood development, also to discuss the importance of screening and early intervention. We also will be providing some basic information on autism, and one of our main goals for today is to introduce some basic best practices of interpreting on child development and developmental delays. That said, we'll just be providing a basic introduction on best practices, and you can stay tuned for a later webinar, possibly in late winter, early spring, that will really go more into detail on best practices for interpreters on this topic. Today's speakers for the webinar are myself, Dr. Jennifer Hall-Lande, and I'll be talking about concepts of early brain development in the early childhood years. Katy Schalla will be talking about screening, and she's from the Minnesota Department of Health. Shawn Holmes, also from the Minnesota Department of Health, will be giving us an overview of the Minnesota's Help Me Grow. And Asli Ashkir will be providing some basic information on autism, and she is also from Minnesota Department of Health. Our goal for today is to assist interpreters in better understanding the terminology and language you may hear around early childhood screening, early developmental milestones, autism, and this is geared to interpreters both in educational and medical settings. And again, some key concepts and vocabulary that you will hear today that may or may not be new to you. You'll hear us talk about developmental screening, child development, specifically early childhood development, disability, and evaluation and assessment. And I just wanted to give a little credit to the project that I work on at the University of Minnesota, the Minnesota Act Early Project. And what that project is, it's a public health outreach project promoting education around early developmental screening and early intervention with very young children. We promote both the Learn the Signs Act Early campaign resources, but also we help promote Minnesota's Help Me Grow early referral system. So we often ask, why intervene early when we talk about intervention? What we know about early brain development and those early years of birth to 3, it is a very active time for the brain. What we say is that the neurons, which are brain cells, form their connections that are most flexible between the ages of birth to age 3. Over time, they can become more resistant to change. So when we talk about ideal timing for early intervention, we want to hit those key birth to 3 years when their brain is most flexible and most responsive and receptive to early intervention. And again, I said I would talk a little bit about early brain development and why it's important to both developmental screening and monitoring of developmental milestones. Neurons or brain cells form in the first months of prenatal development. These brain cells or neurons migrate to the correct places in the brain based on genetic timing, signals the migration of these brain cells. When a baby is born, they're born with about 100 billion neurons. That's a lot, and it's enough brain cells to learn almost anything. You think of all the different environments that a baby may come into. They may come into an urban environment or a rural environment. They may speak English or learn French. Really, that brain needs to be receptive to learn almost anything. And it's also why it's an ideal time for early intervention and why we want to catch delays in development as early as possible. I like to call this slide beautiful brain wiring because I think it's a very beautiful and elegant process how our brain wires during these early childhood years. As I said before, experience in a child's life helps builds the structure of the brain. You may have heard the saying, neurons that fire together wire together. And a neuron has about 15,000 synaptic connections or synapses. So neurons, again, that fire together as a child is learning, then wire and help form the structure of the brain. And these synapses or connections grow and change as a result of stimulation in a child's environment. And I'd like you to keep thinking as I talk about this, about the importance of early intervention. These connections are strengthened through experiences. So you think about a child, for example, if they have a delay in language, we want to come in and intervene while that brain is wiring so we can help form more of those connections that are strengthened through experiences and exposures to something like language. And again, you keep the connections you need and let go of the ones you do not in terms of brain development and connections. So early experiences and hence early intervention are crucial. The majority of connections between neurons are made by age 1. So that time of birth to age 1 is a time of significant brain growth and change. And approximately 80% of connections are made by age 3. One piece I think is really interesting and highlights how much change and growth is going on in that brain. But the child's brain uses about 60% of the nutritional intake during the first year of life. That's an approximation, but it's very high, and it's also why things like baby formula and breast milk are so high in fat and calories, because that brain, the whole body is developing, but a baby's brain really needs a lot of calories and fat to help grow and form the connections it needs. And after age 10, brain growth levels off significantly and pruning begins. And from birth to age 10, the brain is twice as active as an adult brain. And again, we're giving you this information today to help form an understanding or a foundation of early brain development and some of the discussions you might hear when working as an interpreter about why early intervention and early experiences are so crucial in the life of a child. Another term you may have heard in terms of the young and developing brain is brain plasticity. The young brain has what we call neuroplasticity, in that the brain changes and responds to information in the child's environment. We say it's a malleable or changeable brain at that age and highly susceptible to interactions in the environment and exposures in the environment. So if we have a delay, we want to get in there and intervene early so that we can have the greatest impact in a child's development. But delays in the early years may be overcome with later intervention, but the process will be significantly more difficult because the brain isn't as receptive to intervention as a child gets older. And we say some of the most sensitive windows are those involving emotional, social, and language development for a child. And those are also some key developmental milestones in a child's life. Probably also have heard this phrase in terms of brain development: you use it or you lose it. Sometimes I think about that in terms of a language. A child may have exposure to another language, or any of us, to be honest, but if you don't use it consistently, it may get pruned, and those neural connections can get pruned, and you're not able to use that information as effectively. But what is used develops stronger connections. So the more a child interacts in terms of communication or social, they're forming some of those strong neural connections during those early years. And development occurs in spurts when the brain is best equipped to learn those skills. We call those sensitive periods, or sometimes even critical periods. And windows close for some skills. Yeah, and a lot of ways, again, a lot of examples I give are around what is a common referral question in terms of developmental delays around communication. We often get a lot of referrals around delayed speaking, delayed communication. It's what parents are often bringing to physicians that they're concerned about. And you think of the early childhood years, what an important time, what a critical time that is for language development, and why we want to intervene early. That young brain is so receptive to communication, and specifically bidirectional communication with the parent and caregiver during those early years. And again, I was just talking about this, but we call these windows, important windows of learning. These are critical developmental periods when particular environmental experiences are especially important. They're moderate to long, but it can vary, and some windows should not be missed as the opportunity to learn these skills can be significantly diminished. And again, I often go to language for this example, but again, these birth to 3 years are such a critical window for language development. We want to intervene early if the child isn't meeting their developmental milestones. Another term you might hear when interpreting is this term that I've been referring to called developmental milestones. These are the developmental skills such as walking, cooing, waving hello. They're the skills or the things that parents look for. We all look for these in our children as they grow in development. When do they say their first words? When do they take their first steps? When do they get their first tooth? And again, children demonstrate milestones in the ways that they play, learn, talk, behave, interact, and move. And monitoring milestones is an important component of early intervention. The programs we'll talk about today, the Minnesota Act Early Project, Minnesota Help Me Grow, really have a lot of nice tools and resources to help parents or healthcare providers or child care providers regularly monitor a child's developmental milestones and keep track of these so that not only a parent can be aware of healthy development, but also know to intervene early if there is a concern. And as I've shared before, there are many benefits to early intervention. Intervention is more effective and less costly when it's provided earlier in life rather than later. And early intervention programs really target the developing brain when it is most capable of change and most responsive to early intervention. And as I've said before, the neural foundation is formed in early childhood that really impacts all future development. And honestly, we say in terms of early intervention that early intervention has the power to change the trajectory of a child's life through really getting in there early when their brain is receptive to early intervention and helping them to build the skills that they need moving forward. One campaign that I want to talk about today is the Minnesota Act Early Project. It's a project through the University of Minnesota, but we have a lot of collaborative partners, including Minnesota Department of Health, as well as Minnesota Help Me Grow, has been very supportive. The campaign goals of the Minnesota Act Early Project are to help increase awareness of developmental milestones and developmental screening, help support parents and child care providers to regularly monitor child development and help them recognize early signs of a developmental delay. Know the importance of acting early and know who to contact for help. And we will really emphasize this. The best place for families to contact or child care providers is Minnesota Help Me Grow. The Minnesota Act Early campaign is really a campaign that helps promote early developmental monitoring, early developmental screening. But really, we really steer families to Minnesota Help Me Grow to help get connected with the intervention services and the help that they may need if there is a concern about a delay. Just a few examples of some of the resources and tools that we have through Minnesota Act Early that parents might bring to an appointment or that you might see in an educational conference. But here's our Milestone Moments booklet. It's a booklet geared towards parents, but child care providers can use it too, that really talks about developmental milestones at certain ages and what a parent can do to support a child's development and when they should act if there's a concern. Another tool that we have is this brochure, Track Your Child's Developmental Milestone. It's a nice user-friendly brochure, and on the next screen I'll show you the inside of it. But we do have it translated into multiple languages, including Somali, Hmong, Spanish, English, and there are many more on the CDC website. And here's the inside of that brochure. This is the Milestone Moments brochure, and it really has select milestones at a glance for ages 6 months to 4 years. And it helps a parent, you see this game board that we have down here, really track key developmental milestones so that one, they can be aware of what healthy development looks like, and then two, note how to frame a discussion perhaps with their healthcare provider if they feel that their child isn't meeting their milestones. We always say there's a wide range of typical development, but this can be a guideline to help kind of frame discussions and help parents to understand. And we have plenty of these that we're happy to share. and how to get more free materials. One resource that I always like to promote, the Centers for Disease Control and Prevention has the Learn the Signs Act Early program that has a wealth of free materials around early developmental monitoring, how to promote early developmental screening, and information about intervening early if there's a concern. There are also quite a few trainings in which you can get continuing education credits by taking some online trainings to learn more about things like developmental delays, autism, just a whole wealth of topics that may be of interest. We also have our own website, the Minnesota Act Early website, and there's the web address there. You can also learn what our Minnesota Act Early project is doing in terms of outreach, as well as it's another place that you can access some free resources. And finally, thank you for listening to my portion of this webinar. Here is my contact information here. Again, I'm Dr. Jennifer Hall-Lande from the University of Minnesota, and I'm happy to answer any of your questions about the Minnesota Act Early project and early developmental screening. And also, I want to give one more plug for our upcoming webinar, specific date to be announced, but that will offer more specific best practices to interpreters around early screening and early development. And now I will turn over to my colleague from Minnesota Department of Health, Katy Schalla.
Hi, this is Katy Schalla. I'm a pediatric nurse practitioner with the Minnesota Department of Health. And I'd just like to share with you some concepts around screening. In child health, lots of screenings are done when children come in for their well child checks. For example, a blood pressure check might be a common screening that you're aware of in the clinical setting. But we're going to focus specifically on developmental, social, emotional, and autism screening today. So I want to describe to you what is unique about screening. So that term means using a standardized tool, which is usually a questionnaire that the parent has to fill out regarding their child's development. And so the tool has been developed by research. They've tested it on tens of thousands of diverse children to make sure that it actually works to identify any kind of developmental delays that might exist or concerns. It also helps us really identify strengths that the child has and what developmental milestones they're already reaching. So a lot of times parents feel really good filling those forms out and seeing how far their child has come for their age. But again, it's a good opportunity to identify maybe some more mild developmental concerns that aren't obvious just by looking at a child in the clinic. So a screening, again, is just a quick tool to check health and development. It is not a diagnosis. So if the child, if the screening result is concerning, it doesn't mean that there absolutely is a problem. It just means that we need to take a closer look and do a more comprehensive evaluation to see if there might be something that's going on. This is kind of a complicated table, but it gives you an idea of when a child comes in with their family for a child and teen checkup or well child check. We do lots of different screenings at different ages. So in infancy, up until they're a year old, we always check how long they are or how tall they are. We check their weight. But we also do developmental, social, emotional screening. Clinics may also do maternal depression screening at the infant visit. And then once they get to be a year old, we add some additional screenings like lead and hemoglobin and autism screening. And then at 2 years, we repeat all of those same screenings. And then there may be still some screenings that happen at 3, 4, and 5 years. So you can see that developmental, social, emotional, and autism screening, along with maternal depression screening, are just several types of screening that happen within the broader child and teen checkup visit or a well child visit. Just for your knowledge to understand the purpose of these different screenings, developmental screening really refers to how the child is coming along in their motor development or how they're using their small muscles and their large muscles in their body. So for example, are they able to pick up a small object with their fingers? Are they able to walk with good coordination as they get older? Developmental screening also looks at the child's abilities around communication and language. And that's both looking at whether they're speaking yet, but it also looks at how well the child seems to hear and understand language and how well they're able to communicate even without words. Another part of developmental screening checks for cognitive or brain development to look at how children solve problems and think about things as they're getting older. And then developmental screening does have a small component of social emotional development regarding the child's feelings and behaviors, but we do an additional separate screening for that as well, to go more in depth on that area. And just for you to know, a couple of the screening tools that are very commonly used in clinics in Minnesota are the Ages and Stages 3, or the ASQ3 questionnaire, or the PEDS questionnaire. There are other developmental screening tools that might be used in school screening settings or in public health. But the parent questionnaire tools are most commonly used in the clinic. So social emotional screening kind of goes above and beyond developmental screening to look more closely at the infant, toddler, or child's relationships with their parents and other people in their life, with how they regulate their emotions. So how do they feel, how do they express feelings, and how do they manage big feelings as they get older. So for example, if a toddler is having a lot of tantrums, that would probably show up on a screening result. The other thing that social emotional screening covers is the infant's sense of security in their environment and with their family, and their ability to explore and learn. Because for babies and young children, that really is how they learn, is by exploring their environment. So a couple of common tools that are used for young children from infancy through 5 years of age. Probably the biggest example is the Ages and Stages Social Emotional Questionnaire, or the ASQ-SE. And then the Pediatric Symptom Checklist is another questionnaire that can be used once a child is 4 years old. So you may see these tools in the settings where you're working. A third type of screening that you may see, especially if you work in a clinic setting or in public health, is maternal depression screening or postpartum depression screening. And these are questions that are asked of the mother during the infant's visit that really look for postpartum depression. And the tool that is most commonly used for that would be either the PHQ-9 or the Edinburgh. So you may run into those. And these are just short tools. They have 9 or 10 questions. And then finally, for screening for autism, it doesn't screen for general developmental issues. It screens specifically for autism, but again, it's not a diagnosis. And it's recommended to be done in clinics when the child is 18 and 24 months old, or whenever a parent or a provider has concerns about possible autism. So the most commonly used tool for that is called the MChat, or the MChat Revised, and there is sometimes a follow-up questionnaire that goes with that. I think one key question that oftentimes comes up with interpreters is these are standardized written tools that are questions for the parent. I think ideally providers might prefer that the interpreter just read and translate the questions for the family, but we've heard and we know that there are sometimes issues in terms of what interpreters feel they are allowed to do or ethically able to do. And so a lot of times staff will read the questions and then the interpreter will translate from there. All right, so in talking to parents about screening, I think this is another area where the role for the interpreter is important. I just want to share with you some things that we recommend for healthcare professionals and other screening professionals as they talk about screening with families, so that you're aware of that and you can think about the language you're using to translate the conversation. We like to normalize screening. Again, it's not a test or a diagnosis. It's just like we check a child's hearing, vision, and their height and weight to see how they're coming along in their development. We also describe it as a tool to see how the child is growing and developing. And we try to avoid words like test. We try to avoid the word fail. You can pass a screening, but if a screening isn't passed, it just means we need to take a closer look. It's not a failure on the part of the child or the parent. And then again, we try to avoid any diagnosis words. So if a child did not, if the screening questionnaire brought up concerns, we would not say things like, well, maybe the child has autism, or maybe they have this or that. We would just say that the screening wasn't passed, and so we want to do a more comprehensive evaluation to take a closer look. Finally, as you are translating the questions for families, you may run into questions where you're not sure what the intent of the question is. And if that is ever the case, I would suggest that you just check in with the provider and make sure that you understand what the purpose of the question is before you try to translate it. It is okay to, if there's a word that the parent isn't familiar with, it is okay to change up the words just a little bit in a way that makes sense for the family. And again, if you ever have questions, just be sure to run it by the provider. This also brings up another sort of ethical issue for interpreters, because sometimes you may notice things that the provider may not be able to identify. For example, because you speak the language of the family, you may notice that the child seems to have a speech impediment of some sort, or doesn't seem to be behaving or developing in a way that appears typical to you. And I think sometimes interpreters are very cautious, and rightly so because of your ethical requirements, to bring up these things to the provider. And this is something that we're going to try to address a little bit more deeply in a future webinar. But certainly if you have concerns, and certainly if the parent mentions any concerns about the child's development, it would be helpful just from the child's health outcomes and their developmental outcomes from that perspective to share that with a provider if you have the family's permission to do so. So once the screening questionnaire is completed, the provider will review the results and make a determination about what to do next. So if the child passes the screening, meaning that the results are within the cutoff that is considered typical for that child's age and gender, then probably they'll just provide more education about child development and suggest some activities that the parents can do at home to help their child continue along with their healthy development. If the results are borderline or we're not sure, then most likely the provider will want to have a deeper conversation with the family, possibly collect some additional information, and they may ask the family to come back to get screened again at a later date. Or they may decide that it would be better to play it safe and refer the child for more comprehensive evaluation. Because again, we want to catch concerns early and treat them early because that's more effective than waiting until they're older. And finally, if the screening result is beyond cutoff or not within the typical development range, then the provider will recommend that the family be referred on for more evaluation. And just briefly, there are several types of evaluation that should occur if there is a developmental concern that comes up on a screening. First, medical evaluation is done by the primary care provider. They'll get a careful family history. They might do some additional testing like lead or hemoglobin. They may consider referrals to a specialist like a geneticist or a neurodevelopmental pediatrician or something like that. Additionally, it's important to make sure that whenever there's a developmental concern, that the child and family get referred to the local school district for an educational evaluation. And that is to determine if the child is eligible for free early intervention services, and Shawn will describe that in more detail in a moment. If there are social emotional concerns or a positive postpartum depression screening, then the provider would refer the family to a mental health provider, either who provides services for young children or for adults if it's the parent, or for the whole family as a unit. And those resources are increasingly available throughout the state. Aside from these more comprehensive evaluations, the provider may also refer the family to early care and education programs, Head Start, early childhood family education, family home visiting through public health, the follow-along program. There are lots of other community programs that are available to help support healthy development. Here's my contact information if you have questions about child and teen checkups in Minnesota. And now Shawn will talk more about Help Me Grow.
Hi, my name is Shawn Holmes, and I work also at the Minnesota Department of Health in the Children and Youth with Special Health Needs area. And Katy had talked about the different types of evaluation, so I'm going to spend some additional time just briefly talking about Minnesota's educational evaluation, or our early intervention system. This is one of those that if there is a child that has some sort of a developmental concern or a developmental delay, that it's extremely important to be able to refer to this for an educational evaluation to see really what's going on in order to support the child and the family, so that eventually, as that child hits closer to school age, the child's ready. So in Minnesota, we call Minnesota's early intervention system Help Me Grow. and it is 2 programs are underneath that title. Part C, which is for children 0 to 3 years of age. There are other names that people will call it: early intervention, birth to 3, or infant and toddler intervention. And then there's also the services for children that are between 3 and 5 years of age. And those are often called Part B, or preschool special education services, or early childhood special education. This was a key reason for wanting to share this information with you, because people use all of this different terminology for the same types of services. And it can be an extremely confusing discussion, especially coming from a healthcare provider who may have just a little bit of knowledge about what happens with families that are eventually referred for this. So giving you a little bit of base information about what these families can expect and what ultimately they're going to be looking for in an educational evaluation. It's important for me to note that it's the Minnesota Department of Education that does provide the oversight for Minnesota's Help Me Grow system and the Part C and Part B programs. So who can refer a child? Anytime there is some sort of a developmental concern, anyone can refer that child. Most typically, we do see parents making a referral to have somebody be able to talk with them a little bit more about what they're seeing with their child's development. The other big referring source is healthcare providers. We also see referrals come in from childcare, from family members or family friends, really anybody that's involved with that child and that family on a routine basis. Is able to make a referral. The one important thing is Katy talked a lot about different screenings. So if there's screenings that have been completed, it's extremely important to share the results of those screenings with that referral to Help Me Grow. Otherwise, what will ultimately happen is those children may be re-screened and go through that same process that they've already gone through. How to refer to Help Me Grow. I just want to call attention that obviously it's probably not going to be the role of an interpreter to refer families to Help Me Grow, but really understanding what that process can look like. Healthcare providers or families can make the referral in several different ways. If they know that the specific school district that that family lives in, they can call the school district directly. They can also use a toll-free phone number, and then there is the helpmegrowmn.org website, where if you click on Refer a Child, the appropriate forms will pop up. And I also just wanted to call attention to this website. They have multiple resources available on early childhood development in many different languages, as well as videos in Hmong, Somali, English, and in Spanish that really show what typical child development looks like. So even some of those parents, if they're not even at a concerned stage yet about their child's development, this is a great resource for families to be able to grab a lot of that information. The other thing I just wanted to point out quickly is it might seem kind of weird for a baby to be referred to a school. And in Minnesota, that is where we have our specially trained early childhood teachers, where these teachers have been trained to work with families that have children as far as a newborn all the way up to age 5. So in Minnesota, that is how we start working with these families. What happens after a referral is made? So regardless of how the referral is made, if you do it online or by phone, it's going to go to the local school district where that family resides, where the family lives. They're going to contact the family, typically over the phone, and talk about any concerns. As Katy mentioned, when screening, what we see is talking about the child's strengths and talking about concerns. The same thing is going to happen on this phone call, where they're going to talk about exactly how that child is doing. Typically what will happen during this phone call is they will schedule a home visit or a meeting so they can come out in person, meet with you, or meet with the families directly, and meet with the child. The main reason that I'm breaking this up into the 0 to 3 and the 3 to 5 is because it looks a little different depending on how old that child is. But typically it is a home visit where they will come in and they will determine eligibility. Keeping in mind that these services and this evaluation component is free to all families in Minnesota, and it is regardless of income or immigrant status. So if we look at the 0 to 3 age, what we see here is a little less stringent requirements as far as determining eligibility. When the school district does come into the home Typically, what will happen is they will conduct a developmental screening if one has not already been completed. They will talk about the child's health status and medical history. They'll look at the child in several different developmental domains, which I'm going to talk about in the next slide here. And they'll talk a little bit about the family, the unique characteristics of the family. The one thing I would like to mention is we have this table here at the bottom where I'm breaking out exactly what's going on in that 0 to 3 and in the 3 to 5. One important thing to consider here is the eligibility determination time frame. So when a family is referred and they have a child 0 to 3, the school district has to get in touch with that family and determine eligibility within 45 calendar days. Once that child hits 3 years of age and in between 3 and 5, the school has 30 days from getting the parent consent. So it's extremely important to know that because oftentimes what we will see also in that 3 to 5 range is that they do not conduct evaluations during the summer. So if a child is referred in May, unfortunately that child, because there aren't school days going on during the summer, unfortunately that family is not going to be connected with until probably the end of September when the school district gets back up and running for the next school year. You can also see that there are some educational need criteria for eligibility in the 3 to 5, whereas on the 0 to 3, the child does not have to present with any kind of an educational need. So there is much more flexibility, and those families are touched much earlier and quicker in that 0 to 3. Hence, we really want to make sure these kids are referred as early as possible. They will look at whether or not the child has what we call a developmental delay. So there are the 5 developmental domains that I just talked about. So there's cognitive, physical, communication, social, emotional, and adaptive. So when the educational evaluation is going on, they're going to measure the child's development in each of those 5 areas. So for a child that's 0 to 3, the child just has to be below the standard in one area of development. And once that child hits 3 years of age, in between 3 and 5, then the child has to be below the standard in 2 or more areas. So again, just highlighting the flexibility of that 0 to 3 eligibility. There's also high probability conditions. So we've briefly mentioned autism, and the speaker after me will talk about that in more detail. That is considered a high probability condition. So children that present with what we call these conditions, you can see a list of examples here. These children are automatically eligible to receive early intervention services. So cerebral palsy, premature babies at 1,500 grams or less, those children that are presenting with high blood lead levels. And then there are also 13 special social emotional conditions that also fall into that high probability condition. I think it's important to remember that anybody referring a family does not need to know whether or not the child is going to meet eligibility. Always make a referral anytime there's a developmental concern, and then that eligibility can be determined with the family and all of the information that they gather through the evaluation. So if a child is found eligible, keeping in mind these are services that this child and family are entitled to in Minnesota, and they are free. Typically what will happen is it's very much at the parent's will as far as where the services are provided. We see most provided at home or in a child's daycare, but services can be provided at a grandma's house or wherever that family feels most comfortable. In 0 to 3, the services are provided all year round, and some of the examples are occupational therapy or physical therapy or speech services. It just really depends on what's going on with that child. In the 3 to 5 age range, it is more in a least restrictive environment. So we do see more of those services being provided in some sort of a school setting. And then we see typically those services are only during the school year. Some children that are already receiving services, they may qualify for year-round, but that is something that is determined on an individual basis. And then the same types of services are provided. So again, examples are occupational therapy, physical therapy, and speech. Regardless of how old the child is in the 0 to 5 range, there is somebody at the school district that helps oversee and provide coordination for these families. There is one person that that family would be able to connect with when they have questions. All of these services are voluntary. At any point in time, if a family is talking with an educational evaluator and they're just not sure about moving forward or they would like to wait, it is absolutely okay for families to say, I'm not ready for this. I think the important part that we really want to emphasize is the fact that making that referral gives the family an opportunity to start having a conversation to learn a little bit more. And then they have all of the information that they may need in order to make the next decisions. Not all of these children are going to be eligible for through an educational evaluation for these services. So we have many other programs that are available that we connect those families to. Katy mentioned several of them, and so I'm just going to quickly review the list. But there's family home visiting and follow-along program. There's Head Start, Early Head Start, early childhood family education, and we also see, the automatic screening at 3 years of age for early childhood health and developmental screening. And a lot of local communities have wonderful supports or places where families can go and connect with one another and receive some support from each other. So I think the biggest thing is that there's always something, if the family is able to connect with the right people, that we can definitely hook them up with and set them on a good track. So here's my contact information, and I also added the contact information for Kara Temple. She is the Part C Help Me Grow coordinator at the Minnesota Department of Education. And I'm going to turn it over to my coworker, Asli, who's going to spend more time talking about autism spectrum disorder.
Hello, my name is Asli Ashkir, and I work with Minnesota Department of Health, Children and Youth with Special Health Needs. So I will present with the interpreters today about autism. Autism spectrum disorder, which sometimes is called ASD, is a developmental disability that can cause 3 significant challenges to the child: social interaction challenge, communication challenge, and behavioral challenges. There is often nothing about how kids with autism look like that sets them apart from others, but they may communicate, interact, behave, and learn in ways that are different from other children. ASD, or autism spectrum disorder, and autism are usually used interchangeably. The word spectrum in ASD means that each person can be affected in different ways. Learning, thinking, and problem solving of children with autism can range from gifted to severely challenged. Some people with autism need a lot of help in their daily lives, others need less. How the symptoms affect a person's functioning depends on the severity and the combination of the symptoms. The signs of autism usually begin early in life, and most of the time they last throughout a person's life. Autism can reliably diagnosed by age 2 years. Diagnosing autism can be difficult since there is no medical test like a blood test to diagnose the disorder. Doctors look at the child's behavior and development to make a diagnosis. It can sometimes be diagnosed at 18 months or even younger. The average age of autism diagnosis in the United States at present is 4.5 years. There is a lot of work that we need to do so that all the kids can be diagnosed by age 2 years. Therapy for autism is most effective by 2 years of age or even earlier. Many children do not receive a final diagnosis until much older. This delay means that children with autism might not get the early help they need. The epidemiology or the prevalence of autism. As per the last U.S. prevalence report, 2014, autism prevalence in the United States is 1.5%, or 1 in every 68 children. 32% of kids diagnosed with autism have intellectual disability. Sex ratio male-female, it is 4.5 to 1. Autism is more common among boys. It affects 4.5 boys to 1 girl. White, non-Hispanic kids are more likely to be identified with autism. Prevalence of autism increased 123% over the last 14 years. So this is really a public health concern in the United States. A study done in Minneapolis in 2010, and the report was published in 2013, shows that 1 in every 48 kids in Minneapolis, and not all Minnesota, it is Minneapolis, were found to have autism. It is higher than the national rate of 1 in every 68. Somali and white non-Hispanic kids were more likely to be identified. Somali children with autism were more likely to also have intellectual disability than children with autism in all other racial and ethnic groups. Many of us have come across parents asking what causes autism. Autism is a complex disorder. Not long ago, the answer to this question would have been we do not know. However, research is now delivering some answers. We now know that there are likely many causes for multiple types of autism. There may be many different factors that make a child more likely to have autism. Among them are genetic factors, biological factors, and environmental factors. Risk factors that can make a child likely to have autism, and the first one is genes. Genes can make a person more likely to develop autism. Autism concordance between identical twins, twins that arise from the same fertilized egg, is 70%, while that between fraternal twins, or twins that arise from different eggs, is 35%. So this is an evidence that shows that autism, some of the autism is from genetics. If taken during pregnancy, 2 medications or 2 drugs, thalidomide and valproic acid, are linked with higher risk of autism. Children born to older parents are at a greater risk for having autism. There is no link between vaccines and autism. More than 20 research have been done both in the United States and other parts of the world, and there was no link found between autism and vaccines. Vaccines are very important, and they protect our children from many fatal childhood illnesses. My colleagues have already discussed about developmental monitoring, and it is important. Developmental monitoring is important for all young children, particularly from birth to 5 years. Caregivers such as parents, healthcare providers, and early educators should be aware of the developmental milestones so that whenever there is a concern, that they can report to the care provider of the child. Let me take you now through the 3 challenges that children with autism show. And we will take first the social interaction challenge. A child with autism does not respond to name by 12 months of age. Usually, by the age of 8 to 9 months, children respond or look at when someone calls their name. But a child with autism, even at the age of 12 months, may not respond. Child with autism avoids eye contact or makes very little eye contact. A typical child or a normal child interacts with others by looking people in the eye, copying words and actions, and using simple gestures such as clapping and waving bye-bye. A child with autism prefers to play alone. This might be it might be a hard time for a child with autism to learn to interact with other people, or might not be interested in other people at all. They have a flat or inappropriate facial expression. Looking at their face, someone may just suspect there is something going on with this child. This child avoids or resists physical contact. When a parent tries to hug and kiss them, they just resist. They are unable to understand other people's feelings, and they get upset by minor changes. These kids often thrive on routines. A change in the normal pattern of the day, for example, like a stop on the way home from school, can be very upsetting to them. They might lose control and have a meltdown or tantrum, especially if they are in a strange place. The communication challenge, which is the most important one because most of the parents will identify or get concerned when their child does not say a word or two at a particular age, particularly at age 1 year. The child with autism has delayed speech and language skills, delayed language skills. Each person with autism has different communication skills. Some can speak well, others can't speak at all or only very little. About 40% of children with autism do not talk at all, whereas about 25 to 30% of children with autism have some words at the age of 12 to 18 months of age, and then they lose them as they grow. Many parents mention that my child used to speak but stopped speaking. So this is the reason, and this is one of the signs of autism. They repeat words or phrases over and over. Also, they reverse pronouns, like instead of you, they may use I. They give unrelated answers to questions. If you ask someone with autism, do you want some juice? He or she might repeat, do you want some juice? Instead of answering your question. They use few or no gestures at all. Does not say like bye-bye when parent is leaving for outside. They do not point or respond to pointing. When you point to something or some parts of their body or a picture on a book, they will never respond to that. Kids with autism who speak might use language in unusual ways. They might not be able to put words into real sentences. Some say only one word at a time. Others repeat the same words or phrases over and over. Some children repeat what others say. The behavioral challenges of children with autism. These children have repetitive behaviors. For example, they line up toys or other objects. Whenever they have toys, instead of playing with the toys, they just line them up. They play with toys in the same way every time. You find this child doesn't change because they like routines. They like parts of the object, not the whole thing. If they have a truck or a car, you will find them playing with the wheels rather than the whole truck or car. It's very organized. They organize everything very well. They have obsessive interests. Some kids with autism may develop routines that might seem unusual or unnecessary. For example, a child might try to look in every window he or she walks by a building. Not allowing them do these types of routines might cause severe frustration and tantrums. Kids with autism might spend a lot of time repeatedly flapping their arms or rocking from side to side. They might repeatedly turn a light on and off or spin the wheels of a toy. These are behavioral challenges that children with autism have. Some of the parents may also complain additional symptoms or additional signs. They include like hyperactivity, a child who is acting without thinking, and that causes sometimes self-injury. Some of them are aggressive towards their caregivers, their parents, their siblings, and they also have short attention span. They quickly keep changing, moving from one action to the other. Kids with autism have unusual responses to touch, smell, sound, sight, taste, and feel. For example, they might over or underreact to pain or to a loud noise. They might have abnormal eating habits. They limit their diet to only few food items. Others might eat non-food items like dirt or rocks. They might also have issues like chronic constipation or diarrhea. Parents complain that the child has chronic constipation or diarrhea. They might have odd sleeping habits. They also might have abnormal moods or emotional reactions. They may laugh or cry at unusual times, or they may show no emotional response at times you would expect one. They might not be afraid of dangerous things, and they could be fearful of harmless objects or events. So these all things there are some effect on their senses. Another important question that we always get is autism treatment, how to treat autism. And the best answer is whenever a parent has a concern, please bring this concern as early as possible to your care provider and other resources that have been shared before me, like Help Me Grow and district schools, so that your child can get the help they need as soon as possible. There are different types of autism treatment that can generally be broken as following: behavioral and communication approaches, dietary approaches, medication, and complementary and alternative medicine. I want to tell you that there are no medicines that can cure autism at present or that can treat the core symptoms. However, there are medications that might help manage like the high energy levels, the hyperactivity. There are medications that can help with the focus or the attention span. And some children who have comorbidity like depression or seizures, there are medications that can control those too. A remarkable treatment approach for autism is called applied behavior analysis, or ABA. ABA has become widely accepted among healthcare professionals and used in many schools and treatment clinics. What ABA does is it encourages positive behaviors and discourages negative behaviors in order to improve a variety of skills. Also available treatment is occupational therapy, which teaches kids skills that help them live independently as much as possible. Skills might include dressing, eating, bathing, and relating to people. Also, another treatment option available is speech therapy, which helps to improve the kids' communication skills. Some people are able to learn verbal communication skills, and others, they learn how to use gesture or picture boards. So all these available treatment methods are most effective when begun as early as possible. Cultural and child development. In some cultures, the growth of the child is the focus of the parent. For example, parent is just to look how the baby weighs, when the baby gets the first tooth, when baby sits, baby crawls and walks. But they don't look at, is the baby developing normally, the intelligence of the baby. They don't look, what is the baby able to do or to say? And in many of the immigrant communities that you work with, well child screening may be a new concept for them. They usually go and see a doctor when a child is sick, not when a child is healthy. And when they are introduced to questionnaires asking about the development of the child, if they didn't observe the particular question that is being asked, they may not say, I don't know. Most probably they will say yes. Why? Because they are afraid that their child may be leveled with diagnosis or with a disability. Particularly, they are afraid of diagnosis of autism, which is a taboo and stigma in many communities. A child's growth and development are followed through a partnership between parents and healthcare professionals. If a child has a developmental delay, it is important to get help as soon as possible. Each early identification and intervention can have a significant impact on child's ability to learn new skills as well as reduce the need for costly interventions over time. These are more reliable websites where you can get more information if you need. And this is my contact information, and I am at Minnesota Department of Health, and particularly I work with the Autism program. And let us hear from you. If you need me to come to your workplace and present and share more information regarding autism and child growth and development, I'm willing to do that. Thank you. This is the first seminar of a series of 2 seminars which we would like to do for interpreters, and hopefully by late February next year, we are planning to do the second one, and the emphasis of that second one will be the best practices of interpreting, so that we cover what are the best practices so that our community get the best interpreting service available. Thank you.